into researching healthcare practitioners. I'm really looking forward to hearing from them. But just introduce yourself in the chat. I'm going to put my chat on now so I can see who's actually out there. It's at this point where you see people sort of scrabbling with their computers and landing. If you want to put your video camera on so that we can see who's actually out there, that would be nice, because sometimes you're just in the in an anonymous set of initials. Hello, nice to see you. Very welcome. I hope that you've enjoyed the research conference this week. One of the lovely things about it is that it's open to all, regardless of where you are located across Sussex and Kent. All the numbers of participants is going up. I can't see anybody actually introducing themselves and saying where they are on their research journey. Maybe it's because you're all very experienced researchers.
Hello, my name is Diane. I'm one of the specialty doctors who have joined the East Kent Frailty team. I haven't started my research career here, but I would like to start it sooner. I'm just trying to settle down with my job. I've done research back in India and I've published papers. I'd like to know how to do it here.
Okay.
And how things here.
Well, welcome. We're going to hear from a number of speakers, so hopefully it will give you a bit of inspiration. Pop your name and in the chat, and we'll know who you are and where you are. Thank you. Hello, Judy, nurse associate apprentice, right at the beginning. Welcome. Well done for stepping into this group of people. Thank you. And Catherine, I know you. Thank you. So, whilst you're putting in your introductions in the chat, welcome to today's session. I'm Diane Sellers. I'm a speech and language therapist and research fellow working in Sussex Community Foundation Trust. The first speaker that we've got for this particular session is somebody who has been an inspiration to me since 2011 when I first met you. That you have continued to inspire as you have progressed your own research journey. And now you have landed a professorial role at King's University. We look forward to hearing from you and hearing what you have to say. So shall we get going? What have we got? How do you go? There you go. Do you want to start, Catherine?
Okay, thank you. So welcome everybody. So my name's Catherine Evans. I'm a clinical academic in palliative care and community nursing. I've been in a joint role with the Trust, you're absolutely right, Diane, since 2011 as a clinical academic. And the Trust have supported me in my career progression from a clinical lecturer, so my first sort of postdoc post, right, oh, thank you, somebody showing my slides, thank you, that's very kind, right the way through to professorial chair. So it's been a very long and fruitful journey that I've thoroughly enjoyed and felt very privileged, really, that I've been able to combine a career as an academic and as a clinician. It's something that for nurses, midwives and allied health professionals is a less well-trodden path. It's also challenging for doctors and dentists and pharmacists as well. But it's something that over time that the National Institute of Health Research and Care have been investing in, and that has enabled individuals like myself to pursue a career as a clinical academic nurse. So I'm going to talk about my journey and then some of my tips really along the way. And my title was very much from being a curious undergraduate, which is, as I put in the chat for me, is when my first exposure to research was as an undergraduate doing a BSc in community nursing. And that passion for research and the difference it could make for clinical practice has remained with me, really, and has really been the main sort of energizer as to why I pursued a career as a clinical academic. Next slide, please. So I'm going to give this talk. I'm going to focus on often what's seen as the sort of the research journey, probably for most of us, that we begin with a first exposure to research. And just as Diane's just said, for some of you, it might be, you know, joining the session today or joining some of the earlier sessions during the week. So that first exposure to research is really important, that individuals begin to think, yeah, this is interesting, this is something I'd like to know more about. And that's really how we all begin. And then it's our education in research. So just like with our clinical skills, that as in research, we also have to undertake training in research. So undergraduate, postgraduate, doctoral, right the way through, so that we are competent as researchers, as scientists in what we're doing. And then finally, right the way through for me to embedding research in clinical practice. So that's very much about leading and co-leading research studies. And importantly for me now, at this stage in my career as a professor, is very much about building research capacity. So building the next clinical academic leaders in across the health professions. Next slide, please. So I'm going to start with my first exposure to research. So when did this journey begin for me? Next slide, please. So my first exposure really was an undergraduate in community nursing. And I have to say, though, for me, this built on what was already probably nearly 10 years as a registered nurse. So I'd qualified as a nurse. At that point, I was already a senior sister in haematology and in oncology. But I was very mindful of two things: that if I wanted to progress a career as a nurse, I really needed to have a degree. And I didn't particularly want to have to do that part-time. So I was in a very privileged position that I was able to go to university and study full-time as a mature student, and able to study community nursing. So one of the things for me, that when I'd worked in oncology in particular, was that I was quite appalled at the number of patients who were coming in, who were basically end of life, and they were coming in to receive palliative chemotherapy or palliative blood products, and they were having to travel huge distances to come to a London teaching hospital, the Royal Free. And I thought we really should be able to do better in the way that we're providing care and treatment for people at home or closer to home. And it was that clinical experience that stimulated my interest in community nursing and wanting to train as a district nurse and also as a health visitor. Next slide, please. So my first exposure to research, really, that sort of whetted my appetite, that has stayed with me, and the programme of research that I've built around healthcare for older adults, began as an undergraduate with Alison Richardson, who I'm sure a lot of you know is Professor of Oncology Nursing in Southampton, also one of the nursing leads for NHS England for research. And she gave a lecture around the late presentation of older adults with cancer. So she gave a presentation about people presenting very late with cancer. And she gave some beautiful graphs plotting this over time. And what she said and what you could see is that older adults were always disproportionately represented. So these were adults presenting mainly in the emergency department with a very advanced cancer. And I raised my hand very tentatively, sitting in a large lecture hall, and said, why? And she said, we don't know. And I was absolutely appalled that we'd observed this phenomena for about 10 years. We had data that we compared ourselves with other high-income countries, and we fared as one of the worst. And nobody'd asked older adults as to why they were presenting so late with their cancer. So that led to my first research question. And then importantly on the research journey is in publishing that work. So I had the opportunity with Alison to publish my undergraduate dissertation as a book chapter. So this is my first publication. So I think the importance of asking questions that make a difference to clinical practice and to patients, undertaking that work robustly so that it can then be a publication, and then always publishing the research work. Next slide, please. And then for me, having secured a degree in community nursing, I actually then went back into full-time clinical practice, and I practiced as a health visitor, including older adults in my caseload. But my interest in research and the difference that it could make for clinical practice continued. And often for when we're working clinically, the opportunities that we have is to be involved in service evaluations or quality improvement projects. And that was exactly what I did. I was then in what was then Camden and Islington NHS Trust. And we had a huge disparity between the allocation of health visiting resource. And as so often happens in healthcare, the communities with the greatest need, so the communities living in the highest areas of deprivation, had the least resource, and that the communities living in the areas of highest socioeconomic status had the greatest amount of health visiting resource. And some of that was historical as to why that was the case. So I undertook what was a quality improvement project, really, with colleagues supported by the chief nurse, to basically develop an algorithm as to how the health visiting resource could be more fairly allocated based on the population need. So for me, this was opportunity to use my undergraduate research skills. So again, what was important is how using those opportunities for service evaluation enable us to continue to progress our interest in research, to continue to pursue our methods of research and using those methods to impact on clinical care. And again, this led to a further publication in the Nursing Times called Change from the Bottom Up, and also conference presentations at the RCN. So it was a great opportunity for me. And again, very appreciative of the chief nurse, who was very supportive and very keen to develop the capacity really of her workforce. Next slide, please. So now a little bit more really about my education and research. So you can see I was somebody who was curious, asking questions, wanting to get stuck into things, wanting to improve clinical care. So I continued my journey on research, really seeing that research was the way, or a way, to try and improve clinical practice. Next slide, please. So I was very fortunate that though I was working as a health visitor, I was at this point actually on maternity leave, and UCL advertised a post for a lecturer in primary care nursing, and I applied for that post, and at that point I was an undergraduate. But to some extent, the colleagues who appointed me, so Professor Barry Drennan, who many of you probably know as a health visitor, and Professor Steve Iliff, who was a GP, were absolutely passionate about investing in a multidisciplinary primary care workforce. So though I was still quite junior in my research journey, they could see from, I think probably from my publications, that I was somebody who had potential and that they would invest in me and support me. So I'm always very grateful for those sorts of visionaries. So for leaders who, if you like, take a bit of a punt, that they know where they're trying to get to, and they know that they need to support the workforce to be able to achieve that. So that post enabled me to undertake an MSc in gerontology back at King's, enabled me to have much more of an exposure to research in working with the research teams there. And again, my postgraduate dissertation, I then published in the Journal of Advanced Nursing. And then you can see this continual theme for me around healthcare for older adults. So as an undergraduate, as a postgraduate, and then you'll see that's very much the area that I've built my career on. Next slide, please. And so what I want to think about now is the sort of the pipeline. So when I started in research, the NIHR didn't actually even exist. But my progression has very much been along the pipeline. And initiation of this pipeline by the NIHR really in sort of 2009, 2010 is when this began, enabled me to progress as a clinical academic. And the reason I'm showing it is because I think it's important in understanding the research journey of the way that we incrementally build knowledge and research expertise. And also importantly, that we get on and off this pipeline at different points. So for some of us, we might exit the pipeline at masters, or we might continue to a doctorate. But that's also really important to know that that's okay to do that, and important that we do that. So there isn't an expectation that if you are a clinical academic, that you have to progress all the way along this pipeline. It's more about having the research expertise, the passion for research, and seeing it in making a difference for clinical care. So next slide, please. So on that pipeline, I had a master's. I then looked for doctoral funding. So at this point, I said I was a health visitor. I applied to what was then the Department of Health, so that my doctoral funding predates the NIHR. And I was unsuccessful at my first attempt. So I got through to interview. And if I'm honest, I was completely overwhelmed by what was expected of me in going into a room with an interview panel of 10 people. And I just really wasn't well prepared enough to compete at that sort of national level. But when I left the interview, one of the staff who were organising the interview said to me, well, if you've been called to interview, it means that your doctoral proposal is fundable. And if you're not successful, you should apply again. And that was really helpful advice that I was given, that very often for these types of very competitive national funding is that we're not successful on the first time. Typically, you'll get some useful peer review feedback, and then you need to have another go. So for my second attempt, I was then very fortunate to secure a 6-month internship. So that pipeline for the NIHR begins with an internship, like a pre-clinical academic fellowship, for example. And that internship enabled me to work with Sally Redfern at King's College London and Claire Goodman to strengthen my doctoral application, and importantly, better prepare when I was called for interview again. And then the second time I was then successful and secured the doctoral funding. And then my doctoral thesis then looked at the experiences and representations of older people's health in care homes. So the focus on care homes, on primary care, then sort of continued the foundations of my programme of research. Next slide, please. So then at this point, I'm now a postdoctorate and now beginning to make that transition into an early career researcher, which it's always at these points of transition that are tricky. And it's often at those points that we lose individuals on that pipeline. So it's something in capacity building that we need to be particularly attentive to in enabling people, if they want to move from masters to doctoral, from individuals who've secured a doctorate, to be able to continue their research journey to leading their own research or co-leading or focusing on the implementation of research in clinical practice. So for me, embedding is very much been about leading research, building my own programme, and very much along the way in building research capacity in others. So just as from my own side, I've been successful very much through the support, the supervision, the belief of others, and the encouragement of the others to keep going and to develop my skills and expertise. And so as a leader now in research, I'm very mindful of the importance of doing that and supporting others on their journey. Next slide, please. So for me as a postdoctorate, I moved to King's College London. So again, I was returning from maternity leave, so for my third child, and I was quite strategic in that I knew I wanted to continue in research, and I went to the Cicely Saunders Institute at King's College London, because I could see they had a really good track record of research grants and publications in things that I was interested in. So focusing on palliative care for older people, they had a very strong programme around research methods. And I thought they'd be a really good group of individuals to work with. I was also returning from maternity leave, so my postdoc job was really doing systematic review work. And I thought that will work for me as a family, that I'm going to do something that's a bit more desk-based, and I could negotiate to work 4 days a week. So it sort of, suited me well at that point in my career, but also enabled me to locate myself with a team who I thought, this is a group I'd really like opportunity to work with. And that has been a very fruitful decision, really. So I've remained at the Cicely Saunders Institute, which is for palliative care policy and rehabilitation at King's College London. And then in that postdoc job, I was then supported to apply for fellowships. So I applied originally for a clinical lectureship from the National Institute of Health Research. And then at this point, I then was able to partner with Sussex Community Trust. And again, I'm very appreciative of the trust, because I had looked for other NHS trusts, because I'm in London, but I live in Sussex. And I'd spoken to the chief nurses at King's College Hospital, Guy's and St Thomas's. And the bottom line was they had no appetite for a clinical academic in nursing. That has changed hugely over the last 10 years. But the then chief nurse for Sussex Community, I wrote to him, and then he replied and said, I'd really like to work with King's College London. I'd really like to work with Irene Higginson, who was my boss. He had been a Macmillan nurse and he knew Irene's research work. And he said, I don't know what this will bring, but I think it will be a valuable opportunity and I think we should give it a go. And that was, over 10 years ago. So again, you appreciate these people who take a risk. They're really not quite sure what the value is going to look like, but they think it's a good idea and they're going to give it a go. So next slide, please. So my NIHR clinical lectureship, so this was research that was undertaken in the trust. And this was very much about building a programme of research around strengthening the integration of palliative care for older adults who were frail and living with multiple non-cancer conditions. So working with our NHS, our palliative care teams in the trust, and working with our community teams, we were able to undertake the first ever small trial of something called short-term integrated palliative and supportive care. So this was a model of care to integrate specialist palliative care into the service provision delivered by primary care, delivered by GPs and community nurses. And it was short-term, meaning that the palliative care team were involved for up to 3 visits. So to assess, holistic person-centred assessment, review the care, and then evaluate, and then basically discharge the patient from their main caseload with the continuity of care maintained by the community nurses and the GP, and the patient remaining on their caseload if clinically indicated, and being self-re-referring if needed back to the palliative care team if that was required along their journey. So this was an important study because it demonstrated that this was an effective way to provide specialist palliative care to this patient group, remembering that older adults who are frail with non-cancer traditionally have very little access to specialist palliative care services. And these were adults who were severely affected by their non-cancer conditions. So the intervention demonstrated effectiveness on the main outcomes, which was around symptoms. And also importantly, it demonstrated cost effectiveness. And then next slide, please. And then this is a programme of work that I have continued, really, building on the theme around how can we strengthen the integration of palliative care for adults living at home and in a home or in a care home. And what you can see in this slide is some of the examples of how that programme of work has continued to build. So there's a publication on the left-hand side by a colleague, Kim Norja. This was her doctoral study in which she replicated or furthered the model of short-term integrated palliative care for frail older adults in Belgium. And then we've continued the work in thinking about the integration between palliative and primary care in a NIHR funded partnership. So that's what the picture is on the right hand side, and working very much with primary care. So that was with Sarah Mitchell, who is an Associate Professor of Primary Care up in Leeds. And then importantly, continuing that research. So the bottom bit is a study called Mistletoe, in which we have submitted probably about a month or so ago for EU funding to again taking forward this model of care with 12 partners in the EU. So looking again at how can we strengthen this model for adults who are frail with non-cancer conditions to receive palliative care when they're severely affected by their conditions. And then finally, on the bottom right, is that I had opportunity to go and present evidence at the House of Lords on Monday to their select committee on primary and community care. And part of that enabled me then to go and talk about this research and being able to talk about what's really important in how we improve primary and community care for people with life-limiting, life-threatening conditions is that we actually implement what we know works. So that was very much my messaging and the evidence that we had submitted to the committee. Next slide, please. And then moving on then, so having been a clinical lecturer, I was then able to secure further funding from the NIHR as a senior clinical lecturer. So the language of these awards, I'm very aware, has now changed. So they're all called advanced fellowships that you can apply for at different stages. So the clinical one is like an early advanced fellowship, and then a senior clinical lecturer one would be a one that was later in an individual's career. And again, this was then research that was then undertaken with the trust, and this time still looking at older adults, but focusing specifically on frailty and managing clinical uncertainty within our intermediate care units. So this was work that was quite impacted by COVID. So we were able to do the work right at the beginning, which is what's demonstrated on these two publications. So the first one was we were able for the first time to use national data to understand better the population, who are the patients who actually use intermediate care units nationally or community hospitals. And that work enabled us to demonstrate that over 1 in 4 people who are admitted to an intermediate care unit die within a year of that admission. So we were able to identify the characteristics of the individuals who died. And importantly, we were then able to message that the model within those care settings has very much changed over time. And the emphasis now is on the tripatriate model of supporting recovery, rehabilitation in terms of enabling people to maintain and optimize their function, and also importantly, palliative care in the recognition that over 1 in 4 of them are in their last year of life. And then the second publication was work that we then did with the staff and with the patients in those settings, developing an intervention to enable the practitioners to be able to manage care in those settings and during uncertainty better using existing validated tools. So next slide, please. So where all that research then led me to was then for me my first major programme. So this was a 4.7 million programme funded by the Economic and Social Research Council that enabled me to work with colleagues at UCL and bring together the sort of disciplines of old age psychiatry and palliative care. So this programme of work focused on empowering better end-of-life dementia care. So it was something that we have really enjoyed in working together across specialties, that has been a very fruitful way of working in improving care provision for people living with dementia. And what you can see in the photo is one of the co-design workshops that we held, developing our intervention again around strengthening the integration of palliative care for people living with dementia. And some of the individuals in this photo you might recognise, because some of the people in this picture are from our primary care network teams. The Trust is hosting one of the sites for the research study. Next slide, please. And then very quickly, and I think if you click the next bit, just click again. Yeah, brilliant. So where we are with this study, this is what this program looks like. And these programs always look like this. They have multiple work streams of development, understanding the phenomena of interest, and then leading to, for us, an intervention around integrated palliative dementia care, and then piloting that within, for us, community trusts, so Sussex Community and Derbyshire Community Trust, and then also within care homes. Next slide, please. And then throughout my work, one of the components that's so important is about involving the individuals in the work whom you are intending to benefit. So public and community involvement in research is something, again, that has been quite a learning journey, and I think it's ongoing in learning how to do this in a meaningful way that people feel that they can really impact on the research. So this photograph is a picture of one of the groups that we work with. So this is the Dementia and Engagement and Empowerment group up in Bradford. So this, working with this existing community group, enabled us to work with adults living with dementia and current and bereaved carers of individuals with dementia. And again, a huge privilege to work with them in helping us to shape the work so that it has the to maximise the intended benefit for people living with dementia. Next slide, please. And then this slide just depicts some of that activity, really, for me in developing our methods in how we involve the public and community partners in research. So this is some of that activity around developing an online forum, which is what you can see at the bottom. So that online forum very much came from an evaluation that we did of our research strategy within the Cicely Saunders Institute. And the public members said to us that we want to feel more part of the community, and to do that we need other ways to be involved rather than just simply participating in research projects. We want to have opportunity to contribute to your work going forwards. So that was an example of an innovation that came very much from our public members. Next slide, please. And then finally, building research capacity. Next slide. And this is something that I said that I really enjoy. So these are just some examples of the types of things that I've had the privilege to be able to do. So on the right-hand slide is a publication from the Trust Nurse Consultant in Palliative Care, Lisa O'Hara. And this for Lisa is her first ever publication. And it's important because it's an example of an innovation in clinical care. And often with innovations, they're very early along that research journey. So this innovation was a service evaluation, but really important in terms of improving how we manage the dying phase for adults at home. So this was a service evaluation, training and evaluating family carers to give subcutaneous medicines at the end of life for symptom relief. And then the other part of this slide, the capacity building, was the work that I undertook within the intermediate care units, was that was very much with our advanced clinical practitioners. So as an advanced clinical practitioner, the pillar of research is an area that ACPs are looking to develop. So I was able to work with them on that research study, and then this was one of the outputs that they then led on presenting at the Advancing Practice Conference. The other bit on this slide is the Community Nursing Research and Forum, which I co-developed with Ben Bowers. If you've not seen this, then please do go have a look and join the forum. And then finally, I'm the Deputy Director for our King's Clinical Academic Training Office. So that then has been a way for me to focus probably more pan-professionally in developing research capacity. Part of that work also involves medical doctors and dentists, and very much about developing clinical academic careers across the disciplines. And final slide, thank you. Oh, just my top tips: asking important research questions, building collaborations and partnerships. Very much my passion for doing this is about driving clinical effectiveness, but through the integration of research, and then always along the way in building research capacity. Thank you. Last slide. Thank you. Brilliant.
Thank you, Catherine. Thank you so much for that whistle-stop tour, compression of your incredibly successful research journey. It was wonderful to hear from, the starting point when you were a curious nurse who was willing to put up her hand to ask what was possibly felt like a stupid question, or a question that everybody knew the answer to, through to the position now where you're giving evidence in the House of Lords, that you are leading studies on a national and international level. Thank you. So we have got just under 10 minutes of questions from the audience. If anybody would like to ask the questions in person, that's great. If you would prefer somebody else to ask them for you, pop it in the chat. If you put your hand up, then I'll know who you are. At the moment, there isn't anybody. One of the things that I was going to ask was, oh, there we go, Claire. Claire, the floor is yours.
Hi. Thanks, Diane. Hi, Catherine. How's it going?
Hi, Claire.
Sorry, I've just swallowed some water badly, which is the perfect time to put up my hand. I was interested in those first steps, Catherine, about sticking your hand up and asking the question, and how we help and encourage people to be inquisitive and curious in that way at work, as well as in a kind of a learning scenario. It's not to say that people aren't, but I think people have those thoughts and then don't take the next step. And I guess it's about how collectively as the research community we help them take that next step.
Thank you. I think that's a really important question. I mean, I think running this sort of conference, I think, is fabulous. That opportunity for staff to hear from others, see what others are doing, and I suppose it also developing that sort of supportive, collaborative way of working, and being able to identify who within the organisation is interested in research, and feeling able just to email them or message them in Teams and say, oh, I'm interested in what you're doing. Can I have a quick conversation about that? And I think it is so much around those networks and those collaborations. And I think some of it is not feeling shy to put your hand up and just say, actually, I'm interested in this. What do you think? And I think also thinking that there's never really a stupid question. I raised my hand because I was just like, why? And that was greeted by, we don't know. It wasn't greeted by, that's a stupid question. It was greeted by, we don't know. And I think that sort of, honesty and listening and being curious and supporting each other to be curious is probably what's most important. And these sorts of organisational opportunities to showcase what other people are doing so that people can hear from each other and learn from each other and reach out to each other if they've got similar interests that they would like to talk through.
Yeah, I think I totally agree. I think doing it collaboratively across the two organisations is really useful as well, because there are opportunities for us to work across those borders as well as within our own organisations. So yeah, thank you for that.
Yeah, and the Community Nursing Research Forum, which is hosted at QNI, the Queen's Nursing Institute, is very much, that's the intention really, is a big part of that is about connecting community nurses who are interested in research. And it's been, I think there's nearly 500 members of that. It's free, you don't have to be a member of the QNI. But that was all about recognising that often nurses, are poorly connected, and that is a really big barrier for them to be able to progress those questions of curiosity.
Thank you. Lee, would you like to ask your question, please?
Thanks, Diane. Thank you, Catherine. Fabulous presentation. Always love hearing your story. It's just you've gone so far through all of that, as Diane and others have said, and as you've described. And I think some of what Claire's just said as well. There's parts that I think all the way through your journey you can hear of other role models that have supported you and that you've aspired to not necessarily become, but to sort of to understand their world as well. And I think that's what Claire's just been saying as well. I think that role modelling part is often incredibly challenging, particularly in a community setting. And again, the two organisations coming together gives an increased number of role models, doesn't it, for us to talk to and discuss. And I think sometimes when we see individuals, you know, who've come so far on their research journey, it's very difficult to imagine yourself there. And so hearing your story and hearing all of those different sort of times and different parts of your journey. There was something else I was going to say about the different pieces. I can't remember. There was something connected to that I've just forgotten. But yeah, it's fabulous to hear. And I think the role modelling bit is something that, you know, people struggle to identify with, perhaps in community, because we can't hear the role models, because we can't sort of wander down the corridor and knock on a door and have a chat. So it's a little bit more difficult.
Yeah, but I think, you know, the virtual world that we're all now so much more comfortable with has enabled us to do that, you know, that we can just message each other on Teams. We can say, let's have a quick chat. You know, we don't have to trek an hour across the county to go and meet each other, that we can just have a Teams call and then set up a meeting, you know, when there's more of us, or, you know, whatever. It makes it slightly easier to connect. I do think, though, that first exposure to research is so important, because I'm very aware that when you know, otherwise people can feel quite intimidated. But, you know, for me to have got to the end, you know, I began this journey. I was an undergraduate in '92. You know, it's taken me quite a while to get to this point. And then really for me as a postdoctorate, it's been about 10 years. But, you know, I've been able to do that, as you said, through others' role models, looking to others, reaching out to others, and people basically being generous, really, in supporting me and believing in me. And I think that is just so valuable that we do that for each other. And I think in nursing, midwifery, really important that we are collegiate, supportive, enabling, and recognizing that first exposure, and that might be that, you know, you've been a district nurse for 20 years, doesn't really matter. It's having that curiosity that is stimulated and you pursue it.
Yeah, and I don't think I've ever met anybody in research who's not wanted to encourage others to get involved either. So
yeah,
I think reaching out, probably, although the reaching out might be difficult, I don't think the response will be difficult to receive, because I think it'll be a very happy and encouraging response. So brilliant. Thanks, Catherine.
Thank you, Lee. Claire, you've got a minute. You and
oh yeah, I just want to add to Catherine's point. I think there's something really good about recognizing that research isn't an all or nothing thing. You know, you can continue to work in your clinical practice, in your other interests, and flexibly do that around those jobs. So I think Catherine's examples are really great, you know, maternity, fitting it around family requirements and all of those kind of things. And there was a comment about not being released or for doing research. I think sometimes that is an issue, definitely an issue, but there is also creative ways of releasing people that enables research to happen in different ways.
Yeah, and the internships, you know, we have the green shoots that the Clinical Research Network have previously offered, our Applied Research Collaborative for Kent, Surrey and Sussex. You know, it's those sorts of things that are quite discrete amounts of money, but they do enable you to sort of get that first foot. You know, that internship I had enabled me to secure a successful doctoral funding application, and probably without it I would have continued to flounder. So it is looking, you know, which the R&D department, they do circulate things like that. Important just to use those small initial investments, and that's exactly what they're trying to do. They're trying to, you know, build the capacity, often at quite an early exposure.
Thank you so much, Catherine. It was just a joy to listen to you. Thank you very much indeed. I just wanted to say that there is no answer to a question that is not asked. So if you do have a question that is burning, you need to ask it, even if you find out that somebody has already done the work linked to it. It's a wonderful encouragement to do just that. So thank you, Catherine. We're going to move on to our next speaker, who is a fellow allied health professional. Good to see the allied health professionals out there engaging in research. I'd like to welcome Penelope Klebe. Am I saying that right? Penelope Klebe, who's a highly specialist community gastroenterology and nutrition support dietitian from Kent Community Health Trust. Thank you. Welcome, Penelope.
Thank you so much, Diane. And thank you everyone for joining me this afternoon. I think it's sort of from what I was hearing on the last talk, I'm going to be the other end of the spectrum. I'm the very sort of beginning, first steps into research. So I've got a long way to go to reach that same point. But yeah, so I mean, hopefully what I'll talk about will inspire individuals who are thinking of stepping into research to do so, and remind all those people that have been in research for quite a while what it's like to be at the very beginning in the research journey and how it feels. So I'm going to share. Shall I share my presentation, Diane? Is that good? Okay. So hopefully you can all see that okay. So yeah, so I'm a dietitian, so I qualified from King's College in London in 2004, and I've been working in clinical practice ever since. So I've had I guess I've been quite lucky having various sort of jobs and roles where research and more sort of evidence-based practice, I guess, has been really highly encouraged. And certainly I'd say from a sort of a spectrum of opportunities sort of stepping up to research, I have, had opportunities to be very involved, obviously from being an evidence-based practitioner all the way through to obviously now being able to step into research. But I've done sort of audit, been involved in quality improvement projects and sort of service development projects over all the years that I've been working. And I guess the sort of the step into research was noticing things in clinical practice where there were certainly gaps in the evidence base, and having a very supportive manager alongside a very supportive research team within Kent Community Health as well, has given me the opportunity to use my sort of inquisitive mind to go into that sort of research area. I guess one of the other areas of my inspiration has been being the education lead for the British Dietetic Association Gastroenterology Committee, where I've been involved in sort of developing things nationally. I'm involved in the BDA, so the British Dietetic Association update guidelines for irritable bowel syndrome, along with creating their education, the national education programmes for irritable bowel syndrome. Also doing some joint guidelines with the eating disorder lead dietitians within the BDA on looking at sort of disordered eating in people with gut conditions. So working with people nationally certainly highlighted where I wanted to go, I think. So that sort of drove my interest in research more and wanting to sort of get to the bare bones of what all the issues are and how we could best sort of manage them. So certainly through a lot of the journey so far, I've certainly felt probably more like this. than this, but it's obviously a very steep learning curve, and I know that there's a lot more to learn and develop. So I started off as one of the individuals on the Research Champion programme between September 21 and 22. And that is run up at the University of Kent in Canterbury, and that is under the Centre for Health Service Studies. The lead for that is Vanessa Abrahamson, who was a sort of fantastic mentor, along with Beth, who is within our research team at KCHFT. And just to give you a bit of an insight into what the programme covered, so lots of sort of literature searching, library searching skills, formulating research questions. We talked about different types of research, community engagement and patient and public involvement, and collaboration and co-production, ethics and governance, dissemination and impact. And then at the end of the course, we completed a systematic literature review and then created a poster to present at conferences, etc. So my systematic literature review was looking around something that we have, sort of noticed in clinical practice, that individuals with celiac disease, after a year of dietetic support and care, some of those individuals, not all, but some of those individuals are very competent to self-manage that chronic disease. And we developed a toolkit to use with those individuals, where they could easily access and self-refer back into dietetics if they had any problems. But the idea of the toolkit was to identify whether they were following a gluten-free diet, how adherent they were with that, and also monitor other sort of health-related issues that surround celiac disease. So that would be assessing for things like ongoing symptoms, whether they're getting sufficient calcium intake, whether they need annual blood tests, whether they need sort of DEXA scanning, whether they have lost weight, gained weight. So a collective number of different tools within this toolkit that then would allow people to sort of effectively self-manage. And before compiling the toolkit, I'd done a literature review to see if there was anything out there. Through my links with the British Dietetic Association, I had liaised with some national dietetic representatives of celiac disease, and that there was nothing like this available or out there, but I hadn't done a full systematic literature review of the evidence base. So this was really, really useful. What it showed was that actually there is really only one tool, which is an app that was developed in Canada, that you can use for self-management of celiac disease. But the tool hadn't been validated against sort of gold standard measures of clinical assessment and adherence. So the sort of the tools that they used, one of them has been validated for health professionals to administer on patients, but there's actually no tools available for patients to self-administer. So that was the only tool that was really available. There was no written toolkits available, but certainly there was evidence base to show that toolkits could be highly effective. And in some situations, actually, that self-management could improve outcomes versus ongoing clinician input. And certainly the factors that affect adherence to a gluten-free approach was another thing that I drew out of the literature review. which is obviously really essential information to know in terms of how to support patients within that first year of diagnosis, but also what sort of things needed to be considered within the toolkit in order to optimise adherence and self-management. There was another tool that was also once again validated for health professionals to administer on patients, but not for patients to self-administer. And once again, that was to review whether patients were adherent to a gluten-free diet. So this, I know it's quite small and you probably can't see it all that well, but that was just to give you an idea of what the poster looked like. So that was the outcome of the Research Champion programme. And off the back of that, I was really keen to carry on my research journey, and I looked into various options and felt like the ICAP internship, which once again is based up at the University of Kent in Canterbury under CHSS again, but that has Julie McInnes, who's the lead of it. So I've spent the last year on this programme. And where there's been some overlap, there's also been the opportunity for things that, you know, I think going back into lectures after such a prolonged period of time was actually quite tough going. And I think there were certainly things that I didn't necessarily retain the first time round. So this was really good because where there was crossover, it just allowed me to absorb more information than I had before. It included a bit more on types of research. There was a bit more about things like mixed methodology and evaluability assessments as well. And where this one was different is the Research Champion programme was very much related around sort of your area that you were interested in from a research perspective, and obviously literature reviewing something around that. Within this programme, there was a 3,000-word essay on a topic that had been decided already, and that was very much based on what they'd covered over the lectures. So there was essays on sort of things like positive and interpretivist paradigms. There was things about the sort of patient and public involvement. There was an essay on ethics. There was something on methodology. So it was more covering sort of things that we'd covered over the course. But actually, I found it really, really valuable. I did mine on patient and public involvement, which is an area probably I felt less confident with because it's not an area that I've necessarily known huge amounts about in terms of, you know, how do you monitor the impact of things like patient and public involvement, and you know, where do you go to find people that would want to be involved? So that gave me huge amounts of insight and knowledge into the impacts as well that it can have on research, the researcher, but also obviously the public as well. And then the other thing that we had to do was then to present on a research proposal, which, based on the back of my my Research Champion programme, where obviously I was looking at celiac disease and self-management, I continued along the same vein to look into individuals who have a toolkit. You know, what's the, you know, how does that compare to a dietetic assessment, which would be considered the gold standard, and are patients actually being pulled out? You know, are they completing it? Do they like it? Is it actually pulling out or teasing out those ones that do need to self-refer back in? If they're not self-referring back in, why are they not self-referring back in? So it would be a mix of qualitative and quantitative research in order to get a better understanding of what it is that patients do want, and whether actually this toolkit is effective at supporting those that want to continue with self-management. So that's just a bit of an overview of that. So the aims would be to collate evidence to demonstrate the efficacy and experience of people using an existing toolkit, so the one that's already been developed, but also adapting and improving that toolkit based on feedback from more qualitative evaluations, but also information that we gather from a quantitative perspective in order to optimize the toolkit. So we are it is fit for purpose, and it is pulling out those ones that really need to be followed up by a dietitian. And it would be very much, you know, involving PPI, and also hopefully having a sort of a wider or national, international impact. So, I mean, I'd say that there's obviously been a variety of benefits in terms of the programmes that I've done so far. Networking has been, that opportunity has been brilliant, which has really helped with my confidence, because I know there's lots of people out there that I can ask for help and support. In terms of my confidence, that's, you know, really gone up, not just in terms of my research knowledge, but I think also in terms of my clinical practice knowledge as well. My skill set's really improved, so my ability to sort of read articles from journals and be able to interpret them, and also national opportunities to showcase any work as well. And from a wider perspective, I would definitely say that my work within research over the last couple of years has inspired other people within our dietetic team. So we've got somebody completing the Research Champion programme this year, and also just heightened appreciation within the community dietetic service in terms of the importance and value of research. Improved collaboration again between our dietetic team and also the research team within KCHFT, and hopefully improve service delivery and patient care looking longer term. It certainly is impacting on things like standard operating procedures locally for us, including things like this. So this is some of the examples of what from the lit review I've pulled out as really important elements that dietitians need to consider within the first year of dietetic support to patients with newly diagnosed celiac disease. So whereas there are some that we were already very aware of, there are more that have been pulled. So things like psychological well-being, which can have a really huge impact on adherence. Things like sort of giving more information and advice on label reading, which we do, but I think because our clinic consult times are obviously short, like most people, it would be an area that we'd maybe touch on more than go into huge amounts of depth on. And also the more health psychology side of things, so creating sort of specific goals with patients, and supporting them with monitoring and refreshing their goal setting based on how they feel they're getting on and whether their adherence. And also things like the social support element. So once again, we do signpost people to lots of things like the National Celiac Society, but we wouldn't necessarily encourage people to bring family members into clinic or anything like that, so that they get a better awareness and understanding of what a gluten-free diet involves and why it's so important, so that they can offer that ongoing support outside of the clinic. So in terms of next steps, doing huge amounts of research on what the potential next steps are, and I think I've been hugely lucky to secure places on the Research Champion and then the ICAP internship, which I am hugely grateful for, because I am aware that it's not as straightforward as applying and getting something. So I'm keeping options open, let's put it that way, but completing various applications for different options and seeing ultimately what comes of them. But I will continue to be a research champion for community dietetics, and continue to be involved in local research, and continue to do my work with the British Dietetic Association as well. And yes, the journey will continue.
Thank you so much for that. It's great to hear from somebody who says that they're right at the beginning of their research journey. I think you've taken some considerable steps along already, and I would like to wish you all the very best in the next steps for you, as everybody else on this call, I'm sure, would want to do the same. Thank you. So we've got Rob, who's ready to go, but I think we've got time for a couple of questions if anybody wants to ask a question. Ian, hey. Please take the question.
I made it briefly.
Hi, Ian.
Thank you. That was really interesting. Obviously, one of the things that you might find in going forward is working with others in the area who have shared interests or overlapping interests. Yeah. I know one area we've looked at, so we have a community of people, practice for people interested in doing research with children with neurodisability conditions. So things like autism, and one of the big challenges, and one that's been interested in looking at research, is around ARFID. So if that's an area that's interesting or that you'd be interested in, it'd be great to sort of get you involved as well as that sort of journey progresses.
Yeah, thank you so much.
You may not be doing kids, but yeah.
Oh no, thank you.
One of many challenges our families face.
Absolutely, no, I can only imagine. Yeah, we come across it quite a lot in the adult gastro world. Yeah, and it certainly proves very challenging for us as well. So no, thank you. And it's really good to sort of meet people with a similar interest in research, and the research community does seem so supportive, which is always really lovely.
And I think one of the things that we've benefited from the applied research collaboration has been the sort of drive to set up more communities of practice around different areas. So rather than you doing it all on your own, actually realising there's 20 other people across KSS who've got similar interests that you could be working together with.
Absolutely.
Will hopefully help your journey going forward.
Yeah, absolutely. No, thank you so much, Ian. That's great.
Thank you, Ian. Any other quick questions? Lee.
Thank you. Hi, Penny. Great to see you. Great presentation. Thank you very much. I'm just curious. It's interesting hearing you talk about the Research Champions Programme and then the ICAP internship, because a couple of people from each cohort go forward onto the ICAP internship. And obviously there is that little bit of overlap as well, or bigger bit of overlap. When you applied for the Research Champions Programme, can you remember, were you looking for something at that point, or did the advert entice you into that opportunity, or and do you think you might have even found the ICAP anyway? I'm just interested because we're constantly trying to get people, to make it easier for people to engage and to look for opportunities.
I think, yeah, I mean, I think ultimately I was obviously ready to make that change, to sort of move into doing more with the research. And I think that was more around the age of my children as opposed to anything else. And the fact that I felt then I could do that. So it's always been a very active interest of mine, but I think it was just right timing. I do remember seeing the advert, but I think it was a combination of looking out for something to do like that as well. And then the ICAP, I've always been on the research emails for KCHFT, so but I don't think I would have necessarily sort of found out about it. I don't think, if I once again hadn't been sort of proactive to look for it. And poor Beth, me just chewing her ear off about what can I do now?
I suspect
So-
Beth was very happy to have somebody else
yeah,
here.
definitely.
I'm aware that we're moving into Rob's slot. Thank you very much. Very lovely to hear from you.
Thank you so much.
Take care now. Best of luck with your research journey.
Thank you so much, everybody.
So I am delighted to welcome colleague and special care dentist, senior special care dentist. I better read my blurb, hadn't I? Consultant in special care dentistry, working in SCFT. Welcome, Rob. I know that your research journey has developed very nicely, continues to develop very nicely, and I'm going to hand over to you.
Yes, my research journey is developed nicely, but my IT skills haven't, unfortunately. So for all you guys listening, thanks for listening. And as you can probably tell, you might notice a hint of a sort of Welsh accent somewhere there. And that's you're very observant if you notice that. So my title is going to be From Cardiff to London and Beyond. And the Cardiff to London is the front end of the bit, but I guess the beyond bit is where maybe we're at now. So next slide, please, Beth. So qualified in dental school in Cardiff back in 1993, so a fair while ago. And while I was a sort of young dentist, I developed an interest in prosthetic work, which is like your dentures. So I decided I was going to go to London Hospital and do a master's in gerodontology. About a year and a half later, so I guess that's quite young to be hitting this type of thing, but seemed the right time, seemed a good place to go. So next slide, please. So yeah, so there you are. So I went to London Hospital in Whitechapel, and I guess that photo there it's probably from about 3 or 4 years ago. Being a bit cheeky. Yeah, so I went there and I started off doing a master's in gerodontology, which is old person's dentistry. And what I found out there was we did lots of sort of denture work as part of the course. And we were taught by some absolutely fantastic clinicians, but who were very in the mindset that for them, the idea of people having dentures and whatever is, you know, it is important psychologically. But I've sort of felt, I guess, my first sort of peak interest in a research idea was that perhaps not all people worry so much about their teeth and the appearance, their dental appearance, than some of the people who maybe that were being treated by the professors and stuff in London Hospital. So I decided I was going to do a project where I went back home, and through family ties, I quizzed a cohort of miners and asked them how important they felt their teeth were, including for sort of psychological reasons, and I also asked them, were they embarrassed to be seen out without their teeth? And a lot of the ones, the older ones without teeth, were like very much like, well, I've got a set of teeth, and I wear them on Saturday night when I go down the club with the wife. Otherwise, she won't come with me. So it was interesting to see how, you know, 2 different parts of the world did have a sort of different cultural outlook on what was important in dental health. So I guess that was my first sort of interest in research, and that's the first sort of thing which piqued my interest. So next slide, please. So then in 1998, I moved abroad. So I moved to Worthing. And when I first moved to Worthing, I was really shocked because it was really sunny. And I thought, bloody hell, this is going to be sunny all the time. And I think it was one year they had a really warm spring. So I was quite happy to have moved to Worthing because I thought it is like moving to Spain. But you can go home on the weekend. So next slide, please. So then between 1998 and 2014, I'm going to call this phase of my research journey CV building. Did some research and papers, etc. But for me, starting off, I thought what I want to do this in bite-sized chunks. And so the idea was to look for sort of quick win style papers. So such as, yeah, so we did a couple of audits, which we wrote up, and they're still quite popular on sort of things like ResearchGate. People still have a look at these to see, you know, if they can pick up any tips on how to improve quality of x-rays. Next one. We did some case reports, and the one up on the, yeah, we did quite a few case reports in different journals. The one on the right-hand side of the screen, where you can see lots of teeth, and there's a model of a teeth in between. That was a very interesting case we did, where we used a marble and desensitization with patient holding the marble in the mouth to overcome a severe gag reflex. And actually, you can see the before and after shots. So we did quite a good job of this. We managed to do some nice, more complex sort of cosmetic style dentistry on a patient who pretty much before we met him struggled to get a mirror in his mouth. So next ones. And so then from 2014 on, though, I decided I was going to have a proper go at doing some proper research. And the two areas of interest I had at the time was working with Dan, obviously, thanks for introducing me, Dan, was children and young people with swallowing difficulties, because I think as a trust, we've got quite a good expertise in this, and older patients as well, initially with dementia, but since then we've come to just sort of maybe focus on older patients with vulnerabilities in general. So next slide, sorry. Yeah, so a couple of top sticks before we start going into these projects. Teamwork is best. Don't work on your own. Work as a team definitely helps, and you know there'll be people who are willing to help you. And for us, our trust has got a fabulous R&D department. I don't know if Helen's here, but I have to give her a special shout out because she always she's always there when I'm slightly struggling. There we go. Cheers, Helen. Yeah, you're always going to get a shout out from me, all right? But also there's some other key individuals we've had good support with. There's Angie, who works in the R&D department. Will and Ian, we've just done something with autism, and obviously Dan with a younger person thing. And I've also done some stuff with Claire as well. So hi, Claire. And the other thing to bear in mind as well, now for Sussex, it's a bit of a no-brainer. But I'm not sure if Kent, some of your places are probably still quite close to, or close enough to Brighton, the Sussex Medical School. But they run an IRP student placement program, not replacement. And the idea is you run a project. The student comes and works on a project with you, and they pay you it's a normal amount of money in fairness. But actually, they do a lot of the work for you. So they'll do a lot of the donkey work, etc. So it's a good way of having a free research assistant. So we've done, personally, our service now has done quite a few IRP projects. Maybe not for a year or so, but in the past we did one for many years. So next slide. So yeah, so with the Children and Young Person Aspirational Pneumonia Programme, so I was quite convinced that obviously, children and young people with swallowing difficulties often have problems with recurrent chest infections. So we did a number of different stages on that. We did a sort of service evaluation, which is a simple version of research, I guess. And we looked at how parents and carers got on with using non-foaming toothpaste, which was easier to control. From this, we got a poster and a publication. And I think the poster Emma presented the poster at the scientific meeting. I think there was possibly a prize for that. And then we did it. Then that was done with that wasn't done with an IRP, but the stage 2 was done with an IRP student, and we did a systematic review and we looked at what's been done in dentistry in the past, and we did find that not a lot has been done regarding patients with swallowing difficulties and dentistry. Stage 3, we had planned it, but we discontinued because I decided at that point I was going to concentrate on other areas. But there is obviously opportunity if we got somebody involved who will be particularly keen on this to maybe pick it up again. Because I know obviously Diane and everybody in Chailey, which is where we based this, are very keen, and they're very, very research focused in Chailey. They seem to knock out some absolutely stunning quality research, and you know, all of it being very, very practical and very, very high quality. So next slide. So I guess I returned to my roots a bit with the gerodontology, and the idea was I was going to concentrate on the older patient research. And I do feel there's a slight injustice, really. Quite often, older patients are perhaps more marginalised than the rest of the population because they're a little bit out of sight, out of mind, especially if you've got older patients who are stuck at home or stuck in a home. You know, they're not obviously that visible in society often. And the big thing as well, from dentistry, from NHS dentistry at least, 2006 there was a huge huge change in dentistry because they introduced a new contract, and whereas in the past dentists could, general dentists could go out and claim a call-out fee on the NHS and visit patients at home. And myself personally, I did this as a sort of form of overtime when I was younger. That stopped overnight. So then all of a sudden, the number of dentists carrying out home visits for patients just crashed. So obviously that's a little bit of a worry as well. So that helped support my decision to concentrate on older patients. And now I'm labelled as a passionate type, I think, which I don't mind, because I probably am. Next slide, please. So back to a little bit of what Catherine was saying earlier about sort of, she called it something else, I think, but I'm calling it building my own evidence base. So with regards to the older patient program, as you can see, over many years, we've had presentations and publications, and I make sure when I do my papers, I actually make sure that sorry, my computer's trying to restart. I make sure I obviously cite myself, because I want more and more people to read my research, because I do think, at least for myself, I do think that it's an important area, and if people can share my passion, I think older patients will benefit from that. So next slide. So our latest project, and we're finishing and writing this up at the moment, and I did these slides a few weeks ago, so this has even developed on us a little bit since then. But we did a project where we collaborated with Portsmouth and Peninsula Dental School, and we're looking at how we can utilise different skill mix to provide home care, dental home care to patients who are stuck at home. We asked that we went out and we spent time with students in these dental schools, with the teachers in the dental schools, and we also went out then to qualified dental therapists. Now, for those of you who don't understand what a dental therapist is, basically they're like it's a dental professional. They can do like dental hygiene work, but they can also do fill-ins and things as well. So they have got an extended scope of practice, which is reasonably close to what a dentist can do anyway. And as I say, for me, and I think lots of other people in dentistry, we believe dental therapists may be the future in improving access to NHS dentistry, which obviously is a good thing. Next slide, please. So other bits of associated work. So we're working our way through these projects, including this last one with Portsmouth and Plymouth. But these are the things you quite like. And when you do research, these are the type of things which you sort of get involved with. So the first paper we produced was the lead article in the British Dental Journal, and it was reported on by Reuters News. So this lady rang me up from nowhere and interviewed me. And then, of course, if Reuters news agency are involved, it gets sent everywhere. So loads of practices on their information. But we also got a mention in the New York Post. Now the New York Post, for those who don't know, is a bit like, I guess, it's a bit like the Sunday Sport, but for people in New York. So it's not really a high, it's not really a broadsheet, but it's still good to be recognised the other side of the Atlantic. We developed a training video actually in between, and this is to be used for patients or carers of people with dementia and the importance of oral health. And we were quite pleased that the chief dental officer sent a resource pack to all dentists, and our little video was included. So that's quite a good win. And the young lady who helped us direct this, she was a lady who missed out going to university because she was ill at the start of the term. So we commissioned her to make a film, and pretty soon after this, she went on to work on the crew for No Time to Die, and she used our little dementia training video as part of her CV and part of her interview process. I got to be a guest speaker at the Worthing Dementia Alliance conference, and Ellie, who I've been working on with the Portsmouth and Plymouth research project, she won the award, so we had our first bit of funding for research, and we've quite enjoyed using that. And one of the things, interestingly, with that is we're hoping now that the little bit of money we got left over, we are hoping to get this the paper published, but open access as well, so then we can really, really thoroughly share without falling foul of any sort of copyright. We've also developed an older person training resource with the deanery, and we have presented this locally and in the northeast of England as well. So hopefully this will move from strength to strength in times to go forward. So all these little bits of extra stuff have come really from, underpinned by our research projects. Next slide. So my other areas of interest, minimally invasive dentistry. What that means is not so much drilling or injections, which I think everybody is probably quite keen about. Oral sedation, so methods of, making people less anxious, and access to NHS dentistry in general, because at the moment NHS dentistry is a sort of rare occurrence, and people do have lots of difficulty accessing it. Next slide. In the pipeline, this is what we got. So papers to be published in the next few months. So the dental update and the community dental health one. Now these show good collaboration in my mind, and obviously Ian and Will. Ian's on the call today, and Will is one of the sort of the senior researchers for SCFT, and community dental health as well. Obviously, as you say, Claire waved earlier, so Claire's on the call as well. So we try and work interdepartmentally. I've also got a paper in the British Dental Journal agreed to be published in the next month or so, and our write-up of the Dental Therapist DOM project is currently under review with the British Dental Journal. So next slide, please. So future projects. Well, we've got quite a lot of future projects that are lined up, and I guess for me, we're now moving away from, we've got the evidence base into the service development phase, and as I said, we're hoping to utilize our research to underpin any ideas we come up with regards service development. And all these type of things like that. So when I'm going to be putting together some plans in the near future on all these projects, and the projects, when I put forward my plan, will be referenced, and they'll be referenced quite often, as well as with other people's works, with my own work. And I guess the discipline of working on research where you reference your work hopefully adds to the sort of power of the argument for why your projects are good. Next slide, please. And finally, I've got quite into ResearchGate, so I would call this Facebook for boffins if I was explaining it. The idea is you sign up and then people look at your stuff and they like it, and you look at their stuff and you like it, and you can share it with other members and stuff. So yeah, so I've sort of got in a little bit into ResearchGate at the moment. I've got it on my phone as well, so I like to have a little check occasionally to see if I got any more citations. Next slide, please. So there we go. If you want to have a look, there's my profile. If you wanted to have a little look. Okay, next slide. So it's a final finish thing then. Why do research then? And for me, this is the whole point. Why I like special care dentistry, never mind, doing research as well. So, by doing research, you are adding a little bit more variety to your life and a bit more interest. And as I say, if you can keep your interest going and you can enjoy your work, then you'll never work a day in your life. Next slide. So acknowledgements. I think this is the last but one slide actually. So it's quite strange because within our department we've got our usual suspects who help us and dib in and dib out on certain things. There's Ellie, who's one of our senior dental therapists, Parallel, who's our boss, and she's very keen to be involved in projects, and Josh, who's also a senior dental therapist. He is an interesting case because he did sponsored by the trust. He did a master's in research, and he's very good at the sort of methodology, but he also is very, very good at the IT. So that's our usual dental team, or a mixture of any of those four people, including myself. We've got some new external contacts, and there's the profs and senior lecturers in Peninsula and Portsmouth. And last mention, special not forgetting Helen. To be honest, it's so good having somebody who you can go to and you can get help for. And a fair play to Helen, she's never too busy. Oh, if she's busy for an hour. Do you know, you get immediate reply to her. So definite big acknowledgement out to Helen. Okay, I think that's it. So if there's any questions.
Thank you, Rob. Thank you for your really good humoured overview and for making noise in research in Sussex Community Trust, especially in dentistry, where you are leading the way. You really are leading the way.
Thank you.
Thank you. So we've got a I think we've got sort of 4 or 5 minutes before we push play on another presentation. We have got Claire with her hand up, I think. Did Helen put her hand up first? She did. Helen, go.
Well, I don't want to fight you for it, seriously, because that would be, you know, anyway, Rob, what if there was one thing that you wanted to know when you first started that you know now, what would you think it would be?
Um,
I'll put you on the spot, I'm sorry. Think about it and come back to it later. No, go on.
yeah, okay. I think, I guess for me, I probably, I guess I cotton on to things quite quickly because I'm willing to listen. And as I say, the thing which I never realized I would have to do is, you know, the amount of effort and work to go into things is quite a lot. But that then underpins the need for doing stuff as a team, be it a trust-wide team or even your local team. If you try and do stuff on your own, you try and push it through on your own, it's quite difficult. And I think I learned that. So I may have started off not really realizing that, but it's not something I wish I know now. It's something I didn't know when I started, but I did pick up on it quite quick.
Sure, yeah.
Because I knew
Thank you.
that was what I needed.
Oh, thanks, Rob. That's great. Thank you.
Claire.
It's not just because you name checked me, Rob. That's I do actually have a question. It's a more detailed question about a particular study, the Peninsula and Portsmouth study. I was interested to know whether you've spoken to professionals. Are you going to speak to patients as well?
At this stage, I guess the reason why we only spoke to the professionals is because if we're going to develop a project, which I'm sort of writing out now. I've written on the sort of back of an envelope at the moment, so I need to sort of type it up now with boxes and things. But the idea is we will use patient participation at that point to develop maybe the work plan. But the reason we didn't use them in the first place is because if the professionals don't buy in, then you're wasting your time trying to develop anything. I mean, our main questions were around if we wanted to develop something. If you had to summarize the question, it was, if we wanted to develop, you know, you guys to do domiciliary care, are you interested? Are you not? And it's the dental therapist now is the second part, because we have actually sort of asked the dentist that in previous projects, and they're not really that keen. I think, as I say, our older dentists, myself included, we were brought up doing home visits, and therefore we're comfortable with it. Younger dentists have never even thought about doing a home visit, and they're quite scared about it. And the older ones were very much of the mindset, we used to do it, but we're not so keen anymore. So
Yeah,
we
right.
had to find a group of people. So the idea is, let's ask them if they're interested. If they're interested, then we can maybe do something. If they're not interested at all, we won't go anything further on it. But the patients will be in the next bit. And I was writing some notes earlier, and the idea is we're hopefully going to develop a plan through the ICB. And you know, I'm doing this plan, and one of the headings will be patient participation. And they've got a lady there who basically is in charge from the ICB perspective on patient participation. So, you know, that's once again working in a team. I'll be asking her, what do you think we should be doing? And then hopefully she can
Do some stuff for you.
Yeah, exactly.
Yeah. But also, I was laughing. It depends on perspective. I moved to the south coast of England from actual abroad and thought I'd move to the North Pole. So
yeah, it probably was. Yeah.
Thank you. Okay.
Same here.
Ian.
Manchester. Ooh. Carry on.
Cold. Ian, we've got a minute.
Okay, this was probably a longer discussion outside as well, but with my research lead hat and how we actually grow research in the trust, a bit on Helen's thing, going back to the early days, how much difference did it make that you had people like Jenny already sort of in dentistry doing research, and you're in the same building as me and Will? And one of the challenges, I guess, as a community trust for a lot of people is that you can be very easily isolated in a building miles away from anyone else. But how much difference did that make?
I mean, I've done some sort of collaborative stuff with Jenny, but not as much as you might imagine. I mean, I guess one of the defining moments in, you know, name checking you now, is you said, I can't remember where it was, you mentioned the Brighton Medical School IRP program. Once we sort of got involved in that was we said about this 2014, the start of the proper stuff. That was one of the things, and having to do that part of the IRP, I think that was my best start, really. Yeah. I think that's what, and then by doing that, then I got to know Helen. But by that, I got to understand writing a protocol and stuff. So the whole point of doing it through the IRP, I think, was probably a really, really good. If you're talking about proper research, that was the real proper learning of the discipline. Because as I say, unless you've done a master's or something, and you might not have ever done much formally, but the IRP made me focus informally, and I think that was probably quite a big influence as well. And I would suggest anybody who's got a bit of an idea, that's a good start point.
Are you able to say what IRP stands for?
Oh, sorry.
For those who don't know, I think it's probably in the medical world, isn't it?
It's called an individual research project, and basically the undergrad students, the medical students, have to do a project, and they have to follow proper research protocol and all that type of stuff. So they get sent to you, and the good thing is they're keen as mustard to do stuff. You're the ones who supply the ideas of what you're going to do and what you're going to look at, but they will do a lot of the research, and you learn from sort of supervising those, and you can do it pretty much from the word go. I mean, you're learning with them almost, in the first few projects, but it's quite satisfying, and actually to work with younger people who open your eyes to newer things. I think that's very useful as well.
So you get them for about a day a week over a 6-month period, and they come with £750 attached.
Yeah.
There you go.
There's the beginning of your research budget.
Yeah, it is. And
that's what I found out.
The idea is the 700 credit, never sniff for any money, but it's slightly nominal. But actually, what you do and you experience, that is the real benefit from doing that, and it's definitely a cracking scheme.
And
Thank you very much.
Kent are going to follow suit. I know Brighton was one of the first med schools to do this, but I think because Kent and Brighton are linked.
I think we might have to move along now, but definitely Rob and Ian have got experience using this funding stream, and very willing and able medical students. Thank you. So I am aware that we have got 3 things left on the timetable. I am aware that there is somebody on the call whose face I would really like to show. I don't know if Jess Baskerville is there. I don't know whether it's possible to reorder some of the things that are left on the programme. Has Jess gone now? I think she's gone. Okay. We'll keep the order as it was. It's just that Jess is closely... It was because she's closely involved with the YPAG, the Young People Advisory Group, and I was hoping that we'd be able to show her face and show the video. But as she's gone...
No, I can show the video. I'm ready to show the video.
So I wonder if we could do that thing, because it's such an important thing. I've got some words that she's given to me to share with the people here about the Kent, Sussex and Surrey Young People Advisory Group. That's what YPAG stands for. A number of people throughout the week have mentioned the YPAG, and they've been providing invaluable research support through this regular meeting. So it's a group of 8 to 18-year-old young people who meet every 2 months. They are available to give feedback, advice and ideas to researchers who care about making their public and patient involvement relevant and meaningful and embedded into their child health and social care research. There's a lot in that sentence, and it's incredibly important there. They held their very first meeting on 25th of November 2017 and have met every 2 months since then, including virtually during the COVID pandemic. To celebrate their 5th anniversary, the KSS YPAG wanted to produce a tribute to the work of the group, but also something to educate and inspire researchers and other YPAGs. They teamed up with Lara Leslie from Press Play Films, who has worked with some of the biggest names in the UK animation scene. In March 2023, instead of the usual YPAG meeting, the group spent a day with Lara learning the techniques and then working in 4 groups to produce 4 short animated films explaining what the YPAG, our YPAG does, or Kent, Sussex and Surrey YPAG does, and what other YPAGs do, and giving advice to researchers wanting to conduct research with young people. The groups worked separately but linked their films to tell a story. And here is the animation film that they produced. So that's from Jess Baskerville, who sadly had to leave the call at around 1:30. Thank you. Thank you, that's brilliant.
I think I
That is
cut it off
just
before the end of
brilliant.
the credits. Sorry, I really enjoyed that, and then I was trying to get it ready to stop. Yeah, fantastic. Thank you.
Thank you to all of those involved in YPAG, and thank you for researchers going along, sharing their questions in ways that are visual, meaningful, simple, so that the children can make a very meaningful contribution and make the research work for them. Thank you. So 2 more things. I've got the abstract winners to announce, but before that, we're going to hear from the last presentation of the day. We've got a recording from Kate Gray, who's a highly specialist speech and language therapist working in Kent community. And she, does it say what she's got there? I'm going to say what's written here. Investigating the perceptions of healthcare professionals working in a community team in the southeast of England regarding the support required to communicate effectively with people with post-stroke aphasia. So thank you.
Hello, My name is Kate Gray, and I am a speech and language therapist. The master's project I'm about to present represents the most recent step in a journey that started with the KCHFT Research Champions Programme. In 2019. I would like to present my project investigating the perceptions of healthcare professionals working in a community neurological rehabilitation team regarding the support required to communicate effectively with people with post-stroke aphasia. Aphasia is an acquired language disorder that can be caused by stroke or other brain injury and can impact understanding of spoken and written language and/or the ability to make oneself understood. First, I'll provide background context to this project, and next I'll present the project question and a brief outline of the methods and processes used. I will then summarise my analysis and discussion, and finally share my conclusions and recommendations. The presentation will last about 10 minutes. So for background, effective communication between healthcare professionals and people using their services is important to ensure those people are fully informed to make decisions about their health and their options for treatment. Over 100,000 people have a stroke each year in the UK, a third of whom are likely to have aphasia, which may make it difficult for them to understand what a healthcare professional is saying to them or read the leaflets they're given, and may make it difficult to express their wishes, share concerns, or ask questions. Communication is a partnership between healthcare professionals and the people with aphasia, and the stroke guidelines recommend communication skills training for healthcare professionals to support people with aphasia to express their priorities, participate in rehabilitation, and become more autonomous. However, healthcare professionals may not have received such training and so may lack the knowledge, skills, and the confidence required. So for my professional context, I work in a community neuro rehab team alongside occupational therapists, physiotherapists, neurotherapy assistants, another speech therapist, and a stroke specialist nurse, all of whom treat people with aphasia following a stroke. However, my colleagues do not typically receive training in aphasia-specific communication skills, though many have gained skills through experience. Some colleagues have asked for such training and support, and this led to curiosity about the type of support required by my colleagues and the evidence base for the contents of such support. So for my literature review, I found 6 papers about communication training for healthcare professionals. And the common themes of these were the content of training, ongoing support, such as on-the-job coaching, and organisational commitment to allow the additional time for communication in a pressured ward environment. Now, these studies involved hospital-based healthcare professionals in Europe and Australia, but I did not find any literature about community-based healthcare professionals working in the UK, where I anticipated there may be different challenges. The literature does suggest that training may be most effective when tailored to the needs of specific teams. So this led to my project question. What support do non-speech and language therapy trained healthcare professionals, such as my occupational therapy and physiotherapy colleagues, working in a community neuro team, perceive as required to communicate effectively with people with post-stroke aphasia? I recruited a purposive selection of 7 participants in my team from a range of professions, seniority and experience working with people with aphasia, and undertook synchronous, online, semi-structured interviews using MS Teams to gather the data. Data were analysed using reflexive thematic analysis as described by Brown and Clark. The participants checked the transcript and analysis to check the accuracy of the transcript and to ensure they were not misrepresented in the analysis. 3 themes were developed. Firstly, learning about communication and aphasia, including the range of communication strategies and aids that are available, as well as specific supports around setting goals and supporting people to make decisions. One participant raised the difficulty of talking about intimate relationships with people with aphasia and asked about resources to support such discussions. Though I'm not aware of any, I would welcome any ideas or contact about this if anyone listening does have some resources. Secondly, learning about the individual with aphasia, their values and life before the stroke, as well as their communication abilities, in order to be able to provide personally relevant care. And thirdly, learning from experience, recognising their existing skills and experience, but also the need for more opportunities to communicate with people with aphasia and learn from other healthcare professionals, and not just speech and language therapists. So, moving a little more into the discussion around those themes developed through the analysis. The themes were conceptualised as layers of a pyramid, each building on the previous one to represent the layered nature of the communication support required. The base of the pyramid represents education about communication and aphasia, the foundation upon which effective communication could be built. The requirement for more education, including refresher sessions and updates, indicated that knowledge about stroke, aphasia and communication was valued by the project's relatively experienced community-based participants, consistent with literature relating to hospital settings. A new finding was a preference for clinical case studies about people with aphasia known to the participants to support the application of learning and promote the consideration of stroke and communication in relation to all aspects of a person's care. And this was not found in the literature, but is a familiar approach to sharing knowledge in healthcare. In order to apply their general knowledge and skills appropriately, the next layer of support was person-specific information about the individual person with aphasia, so they could build a relationship and plan meaningful therapy through adapting their communication to the individual. This included knowing in advance which communication strategies were likely to be most effective for an individual and having personalised communication resources available. And these findings aligned with the literature for hospital-based healthcare professionals and suggest that speech and language therapists should continue to share this information with colleagues. The final layer of support is gaining experience through practical opportunities to consolidate learning and transfer knowledge and skills into practice. Consistent with the literature, participants' prior experience gained from working with people with aphasia was a significant contributor to their current knowledge, skills and confidence. Participants in this project had at least 8 years' experience communicating with people with aphasia, but nevertheless were keen to gain more experience and hands-on practice. New findings were identified challenges to gaining experience in the community. A couple of participants reported limited exposure to people with aphasia compared to their hospital-based experience, perceiving there to be fewer people with aphasia needing physiotherapy or occupational therapy than on a hospital ward. And indeed, not all people needing occupational therapy or physiotherapy would have aphasia, and not all people with aphasia would need occupational physiotherapy. Participants in this project suggested more joint working, both with speech and language therapists and other healthcare professionals, would be helpful to increase their experience and refine their skills in a supported environment. Participants reported that they often work alone in the community, which can make it difficult to learn from each other. And arranging joint visits can be a challenge due to each profession's different staffing arrangements, prioritisation criteria and time pressures. It may be beneficial to negotiate and prioritise joint working with people who have significant aphasia that may make communication particularly challenging. In conclusion, the project explored the perceived support required by healthcare professionals working in one community neuro-rehab team when communicating with people with aphasia. The findings were largely consistent with the literature about hospital-based healthcare professionals. However, this project provided new insights into the communication support needs of a small selection of community-based healthcare professionals when communicating with people with aphasia. And a new finding of a preference for case study-based learning was provided by the participants, and there was new insight into challenges to gaining experience in the community. This small project was not intended to provide generalisable or transferable findings, but the following recommendations can be made. At a local level, to use insights to develop a communication training programme tailored to the community neuro-rehab team, and to promote the benefits of opportunities for healthcare professionals to work together when treating people with aphasia. At a wider level, I'd recommend to share my findings with the wider organisation, as similar teams may decide that the findings are applicable to them. And also, it would be important to explore the experiences of people with aphasia when communicating with community-based healthcare professionals. Now, this was outside the scope of this project, but would be an important next step to involve them in the process. And more ambitiously, I'd recommend to extend the data through working with a different and larger selection of healthcare professionals, maybe such as those with less experience, and to also evaluate the effectiveness of the communication training programme, which I'm aware would be a huge project all of its own. So in summary, I've shared the background to the project, the methods used and the findings, finishing with my conclusions and recommendations. I have a couple of slides of references, and I'd like to thank you for listening and the opportunity to share the outcome of my project. If you have any questions, please send me an email and I'll do my best to respond once I'm back from holiday, which is why I'm not there today. Thank you so much for your time and attention. I appreciate it.
Thank you to Kate for a very clear, beautiful, polished presentation. Thank you, and I hope you land well from your holiday. Thank you. So we have 2 things left to do. I've got the exciting job of announcing the abstract winners from the conference over the course of the whole conference. We've had more abstracts submitted than last year, which was great. We're really impressed with the quality and the range of specialist areas and professions that were covered in those abstracts. So thank you. We had 2 joint winners. The first of the joint winners is, I'm slightly hesitant about saying the name. There we go. Pilar Bustamante, physiotherapy professional lead. So the information's up on the screen there. Pilar presented on Monday, and I think all of the recordings of all of the presentations are going to be available for you to listen back to. So congratulations to you, Pilar. And the other joint winner was Sarah Crombie, clinical specialist physiotherapist working at Shaley Clinical Services in SCFT. That's the title of the presentation. The panel felt that both abstracts were brilliantly written, with clearly defined aims and rationale, both contributing strongly to knowledge in their particular fields. We have a highly commended winner, who is Kate Gray. You've just heard from Kate, a highly specialist speech and language therapist at KC Kent Community, whose abstract was this one up on the screen now, investigating the perceptions of healthcare professionals with those post-stroke aphasia. So congratulations to all the winners, and their prizes should be on their way to their inboxes soon. Kate's recording, oh, we played Kate's recording because she's currently away on holiday. Lovely, thank you. So let's bring this very successful, very accessible, very exciting conference to an end. It seems to work very well to have it in this format where you can have a whole range of people joining at lunchtime through the course of the week. It seems to have gone down incredibly well. We've had a mixture of national and local speakers and presentations discussing topical themes over the week, particularly for community health research. I think in a community setting, there are so many unanswered questions because each of us work with populations that are generally overlooked. So if you have an overlooked patient population, the chances are that when you raise your hand, like Catherine Evans talked about earlier, and say, why is that? It may well be that the answer is, I don't know, which is actually where the research questions come from. So I hope that this week has inspired you to keep asking your questions or to start asking your questions. The recordings are available. I'm going to just go through the themes for each of the days. On Monday, 12th of June, the topic was inclusive research, that everyone counts. On Tuesday this week, the topic was sustainability, keeping research green. The next topic on Wednesday, 14th of June, was digital, transforming health. Yesterday, that's Thursday, 15th of June, we had integrated care, working together, and particular note here is that Kent and Sussex Community Trust have worked very, very successfully together on the project this year, on the conference this year, as well as last year, I think. So is this the second outing together? Well, that's a successful partnership. Well done. Thank you to all of you who have worked very hard behind the scenes, bringing this conference together and making it so that what you said was going to happen actually happened, and that people who said they were going to speak actually spoke, because it's quite a skill, and making sure that all the technology works and that people have got links. And thank you. There's an awful lot of work that goes on behind the scenes. All of the themes that we've talked about this week are about changing the way that we do things, and we look forward towards the future as we move towards increasing out of hospital care, and therefore increasing research outside of hospitals in the community setting. These themes that we've talked about this week are all encouraging us to look at the bigger picture and look at how we can work more collaboratively across healthcare. Well done to all of you who did submit abstracts and presented. It was a really good opportunity for you to showcase the work that's going on in the community trusts. Just keep those research conversations going. There are networks out there. If you're not sure what network is relevant to you, I think ask your local R&D office. They're always a very, very good place to start. Today is Red for Research Day. There's a few of us sporting red. Who knew? I'm very rarely on message actually, but today I am. This is an opportunity to showcase and celebrate the phenomenal work, learning legacy and innovative treatment systems and techniques that have arisen from research. So thank you. Thank you to Kent Community NHS Foundation Trust for leading on the organisation of this year's research in the Community Week. And thank you to all for your participation and supporting research. Don't forget to reach out to anybody who you think, I just want to ask them a question. Do it. If you've got a question, ask it. Don't be worried about reaching out to somebody who you don't know, you think is, way above your pay grade or whatever it is. Just ask the question. Thank you. Thank you to all for joining. Bye now.
Thank you, Diane. Thank you for a
everybody.
fabulous close to a great week.
Yeah. Thank you. See you next year here.